I would say this trial is much more interesting than the one that I have. So
3:30, 3:30 or 3:45?
no,
All right. This is another study recently published, New England Journal of Medicine, titled Cholesterol Lowering in Intermediate Risk People Without Cardiovascular Disease. So the background of the study is that patients without cardiovascular disease, there have been previous trials showing that statins reduce cardiovascular events. However, the studies looked at patients that either had elevated lipids or elevated inflammatory markers, mainly white people, and a lot of them were done here in the United States. So the question that was asked was, is there a benefit if we extend statin therapy to intermediate risk patients and an ethnically diverse population? So some people have called this almost like a Jupiter 2 trial. It's similar in that patients in Jupiter had normal lipid levels, less than 130. This is going to be a little bit different. I'll show you the inclusion criteria in a second. Everybody in Jupiter had a CRP level, and that was an elevated CRP level, and that was defined as a high sensitivity CRP greater than 2 milligrams per liter. And they were randomized to either rosuvastatin 20 versus placebo. And there was a 44% reduction in cardiovascular events at the time that they stopped the trial. So that could have been inflated because of the premature end of the trial, but nonetheless, they showed a reduction, and it was stopped prematurely because of that. There were some criticisms about the Jupiter trial. Number one, the trial was stopped early. Number two, 9 of the 14 authors had financial ties to AstraZeneca. 3, the lead investigator, Paul Richter, co-held the patent for CRP. And number 4, the sponsor collected the data and monitored the study sites. So the HOPE-3 trial, this was a randomization of 12,000 plus patients, 21 countries, to rosuvastatin 10 versus placebo, and it was part of a 2x2 factorial design, where the other part of the design was patients were randomized to the combination of hydrochlorothiazide and candesartan versus placebo. They looked at an intermediate risk population, so 1% per year CV risk. They had co-primary outcomes, so composite outcome of CV death, MI, and stroke, and then they had a second co-primary outcome that consisted of those 3 plus revascularization, CHF, cardiac arrest. This is the 2x2 factorial design. So you'll see that some people were on double placebo, some people were on both rosuvastatin and the combination of hydrochlorothiazide and candesartan, and then the other groups were either on rosuvastatin and placebo or hydrochlorothiazide, candesartan, and placebo.
This is a hard design because if you just give a stat, then you don't have to worry. Like you don't have to worry about hypotension or hypertension or hypertension. Once you start adding in more pressure, so you have potential for
Yeah.
you have it seems like a higher potential for harm.
But that harm should be weighted equally. So whether you got if you're randomized to statin, you're at the same hypertension risk in that group versus the placebo, you're at the same hypertension risk. I mean, so things do.
I mean, it makes the trial even more powerful.
Yeah, and we'll get into a slide that shows. So these are the inclusion criteria. Now, I think the big take-home message of HOPE-3 that they want to push on to the general public, they meaning the authors, is the following. This is an eyeball test. This is not like Jupiter, where everybody had to have a high sensitivity CRP or everybody had to have lipid level. They're really trying to push that this is an eyeball test. And why do I say that? So they took women 65 and up or men 55 and up who had at least one of the following cardiovascular risk factors. And you can see all of these are things that are kind of obvious. So a waist to hip ratio that can be easily measured in the clinic, greater than 0.85. History of current or recent smoking, low HDL, dysglycemia, early renal dysfunction, or family history of premature coronary heart disease. The exclusion criteria, anybody that was already on a statin got excluded, and anybody that had an indication to be on ACEs or ARBs were excluded. So essentially they're excluding people that have hypertension, right? Because anybody that has hypertension has an indication for an ARB or an ACE or a thiazide. So they're excluding these people, and they're really trying to get just an intermediate risk population. Now you'll see that some people had high blood pressure in the study in just a second. The other thing they're trying to push on you is they're not using cutoff levels for blood pressure. They're not using cutoffs for LDL. It's an eyeball type thing. They had a run-in period of 4 weeks. So what does that mean? So everybody is put on both of these drugs, the rosuvastatin, and they're put on the combo pill hydrochlorothiazide and candesartan to see if they tolerate these medications. So everybody's on the double active medication for 4 weeks, and that way you can weed out the 3.5% that had side effects, the people that were non-compliant, the people that were unwilling to continue, and for whatever other reason. So they ended up with 12,705. So this was well powered, and they also assumed that 20-some% of patients would end up off of the drugs. So they built that into the power. So this is actually, give them credit for a very well-designed trial, and that's why, you know, these were back-to-back in the New England Journal of Medicine. And this is just the rosuvastatin arm, so half to rosuvastatin, half to placebo. But realize that of this group over here, half are also getting the other medication versus placebo, same thing in this arm, because it's a 2x2 factorial. All right, so baseline characteristics. Again, they want an intermediate risk population. So you can see that most people have an elevated waist to hip ratio, 87% in this group and 86%. There's no in-between group differences, so you don't see p-values because these are all the same. There were no differences. You can see presence of 2 risk factors. If you come all the way down here, about half of people actually had 2 risk factors, but one of those was elevated waist to hip ratio. And then some people with hypertension did get into the study. They tried to minimize people with diabetes. So this is actually a very low amount of people with diabetes, 6% and roughly 6%. So again, almost an eyeball test. You don't see LDL cutoffs really. You do see this here, low HDL. This is the inner heart risk score. So this is their own risk score. I'm sure we're all sick of hearing about risk scores because there's a million of them, but McMaster, the group that did the study, has their own risk score that they used. And if you look, the average scores were 14.5, which kind of puts them in a medium risk of 10 to 15. So, but it's bordering the higher risk using their score. And then here's the ethnicities. So again, a very diverse population, although a lot of people are either Chinese, South Asian, other Asian, but there was a good representation from South America. Medications, you can see only 10% were on aspirin, only 8% on beta blockers, only 14%. So again, this is a very healthy population. And that was the point, is to find intermediate risk. So here's placebo versus rosuvastatin. The drop was 35 in LDL. So once you were enrolled into the trial, then everybody got their LDL measured and everybody got a CRP measured. But in order to get into the trial, you didn't need those things. So this is interesting. Why do you guys think that rosuvastatin starts to gradually climb up? Or why does the LDL gradually climb up in the rosuvastatin arm here? Any guesses? Side effects, exactly. So roughly 23% of people came off of the rosuvastatin, but what's interesting, even more people came off the placebo. So it was about 24 or 25%. It was statistically significant. More people stopped the placebo than the rosuvastatin. But that is the reason why you see a slight increase. In, I don't remember, but. All right. A little bit, the results are as follows. So the co-primary outcome of death from cardiovascular cause, MI or stroke, was 3.7% in the rosuvastatin group versus 4.8 in the placebo group. Now keep in mind, this is after a median of 5.6 years. That's important. The second co-primary outcome, they add on these three things: cardiac arrest, revascularization, heart failure, and it's 4.4 versus 5.7. Again, these are very statistically significant. And then the secondary outcome, you take all of those and you add angina without ischemia, and again, you can see that rosuvastatin group did better than the placebo group. And that's the highlight from that slide. This is what it looks like in the Kaplan-Meier analysis. Now, notice they blow up each one of these. If you look at the actual graph down here, you actually have to blow this up to see, because the outcome number is so small, right? There's only 4.8 versus 5.8%. But again, this just shows what we saw on the previous slide, that rosuvastatin lowered the cumulative hazard ratio versus placebo. Same thing for MI, coronary revascularization, and whatever that says up there. Okay. Now, this is interesting. So this is taking into consideration the 2x2 factorial design. Now, remember, some people are on a double placebo. So this is kind of putting the two New England papers together. Some people are on a double placebo. They do the worst. Some people are on only candesartan and hydrochlorothiazide. They do better than the double placebo, but they don't do as well as patients that are on rosuvastatin in red. Now, one of the key points of this study is the combination of rosuvastatin and hydrochlorothiazide candesartan does not do any better than rosuvastatin alone. So this outcome here is driven by rosuvastatin. But now, what happens if you divide this green bar by blood pressure? So if we look at the subgroup analysis, you can see that if you divide the blood pressures by tertiles, this is the baseline blood pressure. So the average starting point for blood pressure was about 138. So if you divide that into tertiles, you'll see that patients that started with a higher blood pressure of 143 systolic had a reduced composite outcome compared to placebo. However, they show that if you started with a blood pressure of 131, you were actually at slightly higher risk. You were actually better off on placebo. So this is a subgroup analysis, so this is not definitive by any means. And if you also remember the SPRINT trial said, well, you should aim for 120. So this is kind of in contradiction to what the SPRINT trial showed. SPRINT trial showed that, shooting people as low as 120 was more beneficial. Here you almost see a U-shaped curve, a U-shaped mortality curve, not mortality, but composite outcome curve. We're not really looking at the cardiac blood pressure, we're looking at what they started out. Yeah, you're looking at their starting blood pressure, comparing it to placebo, and you can see the change in blood pressure was only about 6. So they finished at 137, whereas this 131 group finished on average, 6 again is the change, 125. So it is a little bit, it's interesting why, this, and now it crosses it crosses 1, so it's not significant, but there's a trend in that direction. So I think we have to be skeptical when we see this. I think the people that published this data are saying, well, if my patient comes in with a blood pressure of 143, I'm going to put them on rosuvastatin and hydrochlorothiazide candesartan. Whereas they're also saying, well, if they're 131, I'm not going to touch candesartan and hydrochlorothiazide. But I think we have to be cautious because the SPRINT trial says get them down to 120. So this is a little bit in contradiction to SPRINT, I think. SPRINT is a sicker population.
I don't think you can bring this subgroup analysis up to the level of a trial like SPRINT either.
Right, exactly.
In terms of how it's powered and how they measure blood pressure, they're very careful and specific. They're about SPRINT, but I think comparing a subgroup analysis from one trial to a primary outcome in another trial is a dangerous thing.
Yeah, and that's why, for the purpose of this journal club, I wanted to focus on the rosuvastatin versus placebo. But this was an interesting slide, and just so we can be a little bit, skeptical when, we hear people, they may quote this, that, hey, 143, we're going to put these patients on all these medications and not if they're 136 to begin with. Now, here's probably one of the more, this is why this study is so fascinating, is if you look at all the subgroup analyses, it doesn't matter. Like this was so fascinating to so many people that the baseline CRP does not matter. And remember, Jupiter, in order to get into the study, you needed a CRP greater than 2. So they're saying you need elevated inflammatory markers to get into the study because, we think if you have normal inflammatory markers, you don't need these medications. But this subgroup with CRP less than 2 being almost identical to CRP greater than 2 is telling us that this is happening independent of CRP. And here's the blood pressures. Again, this is just the rosuvastatin, so you can see that rosuvastatin, you're not seeing any harm in patients with higher blood pressure. You wouldn't expect that. You're on a statin medicine, so you're not seeing harm in the higher versus lower group. The lower group probably does better because they're less sick at baseline. Independent of age, independent of all these things. Now, one group in the ethnicity, or a couple groups cross, but as a whole, they do better. And then this was the subgroup, again, from the other paper with canosartan and hydrochlorothiazide. I thought this was interesting. South Asians actually were harmed by taking canosartan hydrochlorothiazide versus placebo. At least there was a trend. It crosses 1, so there was a trend. All right, so the results, what they say based on what they found is the results were consistent in subgroups defined according to cardiovascular risk at baseline, lipid levels, CRP, blood pressure, race, or ethnic group. And I guess, yeah, let's look at the inner. So this is the inner heart risk score. This is their risk score. So even if you had a risk less than 12 or greater than 16, there was no difference. So they're saying, basically anybody who, with the eyeball test, anybody that passes the eyeball test that would fit in this trial should be on rosuvastatin. Felipe?
We know the patient that had a high CRP that was trended down after CRP.
Yeah, that's a great question. So people that started with a high CRP and ended with a low CRP, did they benefit more than somebody whose CRP didn't change? I don't think they published those data yet. Maybe they will. Jeremy?
Going back to that subgroup.
For rosuvastatin? Yeah.
Why do you think it was that people with LDLs above 141 didn't have any significant improvement?
Versus placebo, right?
Yeah. I think that they would get the most of them.
We know they're sicker, but
I think it's hard to make conclusions from reading these courses of the mouse on board class. This could suggest that lower LDL is better. That's kind of the way that I think maybe the higher ones didn't get to low enough, level but.
Or you can also argue LDL just doesn't matter. LDL doesn't matter, period. You could make that assumption too.
Well, I agree with Jeremy, though. It maybe does matter, the lower the better, it's not necessarily the medication.
At baseline.
Yeah, although the people with the lowest LDL, they're good treatment.
Yeah, but you're comparing each group to placebo. You're not comparing them against one another. It went down on average 34, which. All right, I think very importantly, there was no excess risk of diabetes, since that's been sensationalized by the media, and no excess risk of cancer. There was an excess risk of, this is a trivia question, it's actually in the abstract. And Stephen sent out the abstract last night at 6:30. Yeah. All right, cataract surgery. So nobody knows why. There's been some observational evidence that statins are associated with cataract, but there's also been trials showing that it's not. So this question remains to be answered, and there needs to be obviously a meta-analysis of observational studies. All right, number needed to treat. So we said that number needed to treat, so the difference, absolute reduction, was about 1.1%. But this is a trial that lasted 5.6 years. So it takes 90 people over 5.6 years to prevent one composite endpoint. Now, that's not death. That's the composite of either an MI, a CV event, or stroke. If you go to Costco.com and you see that the average cost of rosuvastatin is $264 a month, and you multiply it by 5.6 years times 90 people, in order to reduce one composite endpoint, it costs $1.6 million. So I'm glad you bring that point up, Justin, because I think, you realize it, but not everybody realizes this, right? Primary care providers might think, oh my God, I got to get my patient on rosuvastatin. But if you, look at this carefully and we have this type of discussion, you may say, hey, look, let's put people on generics because, this is expensive. Oh,
So I wanted to ask, 2010 there was a lawsuit with the company against AstraZeneca. That's when the trial actually started. Then years ago, we approved this year.
Interesting. Timely. Yeah. So conclusions. This study basically expands the indication almost. It's actually in line with the 2013 guidelines that say if you have a 7.5% risk of an event over 10 years, that you should go on a statin. So what was their risk if you go to the results? That's how they powered it, but the actual finding was the following. So they had 4.8% over 5.9 years. So what's 4.8 over 5.9 years is about 8%, right? So this is almost directly in line with what the 2013 guidelines said, and that's anybody. That's true. Yeah, you're right. It is high intensity, which would be 20. Yeah. So again, the effect. No patients were from the United States. This is all multi-ethnicities throughout 21 different countries. And then last, there may be a role for hydrochlorothiazide candesartan in higher baseline blood pressures, but this is a subgroup analysis. So just take that, with a grain of salt, perhaps. That's it.
In other words, you're saying that AstraZeneca
Right. So we're just gonna have to produce a whole lot more.